Getting started. Okay. Hello, everyone. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research, and it is my pleasure to welcome you once again to our 2018 Health Policy Seminar Series. But first, and as always, a note about next month's seminar. So please save the date. On April 26th, we will have Dr. Susan Babby, who is the co-director of the Center's Chronic Disease Program, and her co-author, Joelle Wolstein, a Center research scientist, here discussing their findings from their latest study of sugary beverage consumption in young children in California. Now, we all know that beverages with added sugar, such as soda, energy drinks, and sports drinks, are the largest source of added sugar in the diets of both children and adults in the United States. And we also know that adults and teens consume lots of sodas and so-called sports drinks. But did you know that little children, some as young as 2 years old, often consume significant amounts of these unhealthy sugary beverages? Sue and Joelle are going to be talking about the latest data on this consumption, and they will provide a sneak peek at another upcoming study on sugary beverage consumption in general amongst Californians. So bring a nice, healthy glass of water and join us. Okay. As for today's seminar, we are recording it, and it will be placed on our website at the address you see at the top of this slide. If you're watching online, you would like copies of today's slides, please email me, gdriscoll@ucla.edu, and I will send them to you. Please also note we will have a brief question and answer period at the end of today's seminar that I will moderate. And if you want to be kept informed of all our latest research and data, please subscribe to our monthly e-newsletter, Health Policy News. That's the link at the bottom of this slide, and you will get great topical information on all the most pressing California and national health issues there. Okay. It is now my pleasure to introduce today's speakers. For 2 years, Dr. Ninez Ponce, Associate Center Director, and her co-author, A.J. Scheitler, have coordinated a study of breast cancer care and specifically the obstacles that prevent patients and survivors in California from accessing that care. Ninez is a professor in the UCLA Fielding School of Public Health, and A.J. is the center's coordinator of stakeholder relations. Last year, you may recall from our newsletter, at a hearing in Sacramento, Ninez and A.J. presented preliminary findings from the study, and today they are here to present full study findings, highlighting 3 of the most pressing issues. 1, a need for patient navigators to help breast cancer survivors understand and access services. 2, a lack of continuity of care within the complex system of providers, support services, and insurance requirements. And 3, the particular obstacles facing low-income women, including narrow provider networks and time limits on coverage. These findings are summarized in 3 fact sheets that the center released on its website today, and our email address, you can see the bottom of the slide, is healthpolicy.ucla.edu. We've also released a comprehensive report of all the study findings, and you can find it all there on our website, main page today. These publications are required reading for policymakers, advocates, and anyone who wants to make a difference for the 1 out of 8 women who will be diagnosed with breast cancer in her lifetime. All right, before they come up, I just want to make a brief mention that this will be my last appearance at the podium here at the center, as I am moving on after 10 amazing years at the center. The center is a wonderful, fascinating place to work, and it's been really very gratifying knowing that our data and research has been the foundation of many, many laws and policies aimed at improving health in California. One of the best parts of my job is waking up knowing that I will be speaking from a place of evidence based on meticulously collected data. And that credibility is what makes the center unique. We don't just say it, we prove it. The center is part of UCLA, but did you know it is 100% self-funded? So if you value evidence as I do, and the credibility it bestows on your efforts to improve health, please consider donating to the important work at the UCLA Center for Health Policy Research today. And that's the end of my commercial. Thank you, and please welcome our speakers. Thanks so much, Gwen, and thank you for, is it over 10 years? Close to 10 years? A decade of really impactful contribution to the center, and one of them being launching this webinar series that we have, this lunchtime webinar series. I thank all of you who are joining us remotely and for those who are here in the room with us. So this was not just AJ and myself, Dr. Scheitler and myself, but this report happened because of the collaboration with Dr. Beth Glenn, who's in the audience right now. She's Associate Director of Health Equity at the Fielding School of Public Health and also at Division of Cancer Control and Prevention Research. Riti Shimkata, who is at the center, she's a social epidemiologist. Dr. Michelle Coe was here at the center, but is now faculty at UC Davis, and myself. And this could not have been possible without the funding from the California Breast Cancer Research Program and our vital partnership with the California Pan-Ethnic Health Network. So thank you. We're going to go over some context and approach, the key findings and the recommendations, the policy themes that we found in this study, and then hopefully there's enough time for a Q&A and a discussion. But we are available by email. I think we can provide some of our contact information should you want to continue this discussion after this hour together. What's a study motivation? Well, Gwen said it. I think you cannot go through a day without conversations of knowing that somebody has been hit with breast cancer, either a close family friend or a coworker. In 2018, over 20,000 women will be diagnosed with breast cancer in California, and an estimated 4,500 will die of this disease. Now, back in 2015, 2016, when we were already post-ACA, we were making gains in coverage in the nation and in the state. Then the concern pivoted to not so much coverage disparities, but treatment disparities. And the question that was posed by the California Breast Cancer Research Program through their Policy Research Advisory Group was, we know you can get data, you can process really quick, really quickly, although quickly is 1 year, for example. Just data comes about 9 months after. But what we want is to be in the know is what's happening now. We want you to talk to people to get some insights on what the significant barriers are and challenges to access breast cancer treatment in California, and to see if these insights can differentiate whether the experience for a woman is different if they're uninsured, if they're underinsured, or if they're on public or private health insurance. And there was a very specific timeline. Do this quickly. This is not a big data collection research study, but try to be as current as possible and try to get as much stories as possible that can span these different experiences. So again, we started our data collection in the first quarter of 2016. And our insights from patients came largely from advocates, health educators, and navigators that work very closely with patients across different health insurance status experiences. So note, first quarter 2016. The Policy Research Advisory Group of the California Breast Cancer Research Program suggested, well, now that you have the patient side, why don't you have a listen in what's going on from the supply side or the provider side? So we decided to do this, but by the time that we were able to do this, it was 2017. So at the advent of a new administration and during the time that when we were collecting this data, every day we were experiencing changes on possible features of repeal for the Affordable Care Act. So there was a lot of uncertainty during this period,
And so we what we call exploited uncertainty to talk to providers about if they felt that there were what specific features in California would be threatened. So we looked at the patient perspective, the provider perspective, and Dr. Scheitler can talk more about who she spoke with the hope that we can inform, we can move the needle in policy, and policy coming in several flavors here, policy coming in state mandates, policy coming in regulation, policy coming in perhaps practice, guidelines policies for the providers of care or for insurance carriers. So our approach was three-pronged, but it really was the key informant interviews that Dr. Scheitler led that brought the unique insights of this study. Because the narrative synthesis to the barriers to breast cancer care was a lit review that most of us can do pretty well. But the lit review, as we know, of the peer-reviewed literature gets a little dated. You know, the studies are from perhaps 2-3 years ago. But it was important to have to see and to inform our key informant questions and script. And then we tried something called a social media scrape, examination of social media to capture discussions on barriers to breast cancer care. And I have to look at my notes in here, and this was led by Dr. Riti Shimkata because I just got on Facebook. So it's Twitter, Facebook, it's conversations in Twitter, Facebook, Tumblr, WordPress, Blogger, Reddit, message boards, patient message boards that try to follow conversations, but a lot of the message boards were also private because it was a private space. And in looking at various hashtags, hashtag breast cancer, hashtag barriers to breast cancer, what we did find in that space was the concern and anxiety about cost. So with these two ways of trying to find information, it helped with the design of the key informant interviews, but it also helped in what we call triangulating the data and seeing what themes came up, both from the narrative synthesis, the examination of social media, and then the themes that arose from the conversations and discussions that Dr. A.J. Scheitler led with patients and providers. So as I said, round one was ACA, well, we're still in ACA, but round one was 2016, first quarter of ACA, patient educators, advocates, and navigators. And round two was the first quarter of 2017 with primary care providers, breast surgeons, medical and radiation oncologists, medical program directors, administrators, and social workers. So now let's have a listen on what's occurring in the field. I'd like to introduce to you Dr. A.J. Scheitler.
Thank you, Dr. Ponce. So yes, I want to emphasize what Ninez just left off with, and that is that we talk to people about what's happening in the field. And the reason that that is important is that as I go through some of the study findings, some of you are going to say, wait a minute, isn't there a state law that already addresses that particular barrier? And so it's very important to understand that there may be state laws, but what's happening in the field is disconnected from that, and that identifies some areas of gaps that still need to be addressed. So these are some of the major themes that we found: system fragmentation and the need for navigation, insurance and health benefits, cost, no surprise there, cultural and individual characteristics, and then language. I'll go through each one of these in a little bit more depth. So system fragmentation. Breast cancer care is incredibly complex. It is not like going to the doctor, you got pink eye, you're going to get a medication, and you're going to be better. You have to go through a complex system of providers, of tests, of treatments, of insurance approvals for all of those things. And then not to mention the long-term ramifications and the need for support services that aren't really associated with most other diseases. All of these things exist, but whether or not a woman can navigate through them very easily is very different depending on her personal circumstances, of insurance coverage, of the providers that she has access to, and whether or not there's knowledge of the support services that she can get. And what we heard loud and clear about this system is that navigation is extremely important and valuable to access. There is a need for quality navigation programs to help smooth this process for women. Navigators can also help the system too, because of their interactions with women and they're hearing about all of the process, not just one isolated treatment. They view gaps and can identify issues that patients face that sometimes doctors or other providers would be unaware of. There is a difference in perception of the availability of navigation services. The providers that we talked to often were associated with facilities that they had somebody they at least considered to be a navigator. Whereas in the first phase, when we talked to the educators and the advocates, most of them ended up serving as de facto navigators because a woman didn't have any place to go and they had maybe a good relationship with this person and came back to them. And that's kind of another issue that we had identified, is that there's no standardization of navigation services. We heard from people who got navigation services from their insurance company, but also from people who were able to go to, for example, a comprehensive breast cancer care center, and there were navigators there. So there's how you access navigation services, there is certainly no standard, nor is there any standardization of what you could expect from somebody who called themselves a navigator. What kind of services can they offer you? What kind of skill set and knowledge do they have? And we heard on this from both sides of the discussion. Again, from providers who said, hey, it's so great my patients have this, and from people who interacted with women and lamented the fact that these people were struggling to navigate the system by themselves. Another major barrier was insurance and health benefits. Insurance status matters. And depending on whether or not you have private insurance you got through Covered California or a public program, it vastly changes what your course of treatment could be, who you have access to, how timely your access is going to be, and how many providers you may have to choose from. Add in a place that's rural, or a place like Los Angeles, which is so big that getting from the east side to the west side to see a provider can be hours worth of your time, is very, very different. Also, when we talked to providers, they added another level of barriers that they saw, which was the approvals process. And this was not limited to Medi-Cal, although it was most often associated with the public program. There were disparities among different private insurers as to their response times and their approvals process and what they would approve. Again, we heard frustration about Medi-Cal rates from everybody, so that was a very frequent theme that both the advocates saw and the providers certainly saw. Cost. Cost is certainly not an issue that's exclusive to breast cancer. It is a common theme all over healthcare. But given the complexity of care that is involved in battling breast cancer, there are so many things that, as one provider put it, get left out of the cost model. Childcare, transportation, need for services during recovery from treatments, lost time at work, all of these things add up, and none of them are covered by insurance. So women face additional costs above and beyond their deductible and their copays. There was also a call out for the need for financial advisors, given this situation, that so many women are going to be unprepared for all of the costs that are treated. They may look and say, okay, I've got a $20 copay every time I go to the doctor, but they don't realize that every time they have chemotherapy, they may need a couple of days off of work to recover. And for a wage worker, that is very significant income that they may or may not be taking into consideration. Again, there was just so much hidden cost that everybody laments. That we also heard about some innovative programs to try to help address those costs, But again, whether or not you have access to those programs was very much tied to where you lived, who you talked to, and whether or not you had a navigator who was knowledgeable about them, who could connect you with those programs. So that was very significant. Another thing that's very important is that cost is not an issue only of the low income. There is this perception and very much a misconception that if you have a job and if you have private insurance, then you can quote unquote afford to be sick. But if you have 10, 20 visits over the course of a couple of months and you have a $20 copay every single time you go, that adds up quickly for anybody. Cultural barriers. This, again, not exclusive to breast cancer, but some of the cultural barriers are very focused on cancer. Cancer is seen as a death sentence in some cultures, and so why are you going to bother trying to treat it? There's also a lot of cultures that don't have quite the health literacy that we do, particularly among our immigrant communities. One provider I talked to saw a large Hmong community and said that there were some words that he tried to use that didn't even translate into their language. And he was trying to give basic anatomy lessons to some people to try to help them understand the diagnosis and the care that they were given. Then there's just fear, stigma. Some people don't want to seek support. I heard stories of women who would travel outside of their own community because they didn't want anybody in their community to know that they had the disease. And among a lot of immigrant communities, there's a very big maternal force. Breast cancer obviously affects women predominantly. And my perception is that my primary job is to be a caregiver to my family, am I going to always take the necessary time off to take care of myself, to go through the treatments and the care that I need when I feel this other obligation? Again, there's also a lot of immigrant communities that don't come in with a high educational attainment. And so there is an added barrier in the doctor's office when there's just trying to communicate about the complexities of what cancer is and what the treatment needs to be. Additionally, this extends outside of the doctor's office. There are very few support groups that might be in language or in a cultural setting that is appropriate for women, where they will feel comfortable to go in and share what is inherently an incredibly personal journey. Language. Now, obviously, this intersects quite a lot with culture, but we heard it so strongly from our stakeholder interviews that we felt the need to give it its own category. Excuse me. Obviously, it impacts health literacy, and it has effect on whether or not women can get support services. But it also overlaps in the doctor's office, and we heard sometimes that if another interpreter wasn't available, or if a woman wanted a family member to be the interpreter because she was most comfortable, doctors were put in the position of having to have a child interpret to their mother some very sensitive things that were going on, and that puts the doctor in a very precarious position of doing what's right or doing what is going to make the patient listen. And those two things are at odds often and can really prevent a woman from getting good care. The other issue is that translation can't just be grammar. It has to extend to culturally appropriate conversation. Again, heightened in a very sensitive issue such as breast cancer. As Dr. Ponce mentioned, we conducted the second round of stakeholder interviews with providers during the part of 2017, where the CNN headline every morning was the new conversation about what Washington was going to try to do to repeal the ACA. And on a weekly basis, depending on who I was interviewing, the conversation went very differently. But they were all very happy to talk about their opinions on the situation and what was happening. Now, we've specifically asked providers about their concerns with the repeal proposals. And of course, the first thing they said was uninsurance was going to go back up, which was going to have a direct impact on more people going back to the emergency room. There was also going to be a real increase in reliance on public programs, which, as you may remember a few slides earlier, public programs and for low-income women have their own challenges with them. And so all of those things were just going to be exacerbated under the ACA. At the end of all of the interviews that we did with the stakeholders, we gave them the opportunity, after they just said, here's all the challenges I think are happening, to give recommendations. Okay, sir, what do you think is going to help address the challenges that you just talked about? And after this conversation, almost all of them said single payer healthcare. They said it. Just sharing with you my findings. So in the report, you will see that we went through and looked at the possible recommendations that you could have to address the barriers that we identified in the study. And some of them could be considered by policymakers or regulators. Some of them are system changes that could happen within different healthcare systems, and some of them are open for community groups to maybe step in and help make some changes. We do have some specific recommendations based on some of the various buckets of your insurance status that you might fall into. But we also have over here on the right-hand side recommendations that would help all the statuses, because one of the things that we found during this study is that regardless of your status, regardless of your insurance, regardless of your income, you were not immune from any of these issues. Everybody had some barrier that they faced that could help, that could stop them from getting the high quality or timely care that they need. So after we presented each of these findings back to the California Breast Cancer Research Program, their policy research advisory group identified 3 specific areas that they thought, okay, they're kind of the most salient to breast cancer and timely for action that could happen right now. So I'm going to go a little bit deeper into those. These are also the 3 areas that we did separate fact sheets for, in addition to our report, that are available on the website. So the first one is improve navigation services. As I mentioned, there is a real desire and need for these services, and given that they can help a woman get on a treatment course and stay through timely care, they could provide in return on investment for the health systems. However, there hasn't been any studies of that yet. When we did the literature search, this is an emerging area. And so there's one promising study that's in the field right now, but there isn't any literature that directly shows. However, we heard loud and clear from people who are in the field that whether or not it's got a real return on investment in the finances, it definitely does for the women who need the care. So you could look at reimbursement for services. You definitely need to develop the quality standards so that, again, when someone has the title of navigator, there's an expectation of their knowledge and skills and resources. And speaking of resources, because so many people are currently just sort of de facto navigators for these women who need it, there could be a repository of information created. If I'm an Asian American woman and I'm about to go through chemotherapy and I'd like to find a wig that's going to be appropriate for me, and I go to the receptionist at the chemo place that I get my treatments, I hope that she can answer that question for me. But if she's never answered it before, she might not know. It would be great to have a repository of information that that woman could go to be able to identify the service and connect the woman with it. Also, at the system level, they could improve integration. This is not going to be easy in some places where there's already not an existing one-stop place for a woman with breast cancer to go, where all of her doctors are going to be, where all of her tests are going to be, where her treatments are going to be, so that there's discussion among her providers. But to any degree that could be improved, that would be a real help to women needing care. One of the other areas that they thought we could look at is the programs that exist for low-income women. In the 2014-15 year, more than 174,000 women got screened for either breast or cervical cancer under California's Breast and Cervical Cancer Treatment Program, BCCTP. Sorry, Every Woman Counts. The Every Woman Counts program. Many of them, because they got screened into that, they were low income, they're going to be moved to the BCCTP. Those two programs right now are not connected in a way that makes the transition from you have the diagnosis over to here's the public program that you can get on to start your treatment. Or if they're going to go into Medi-Cal, that is also not a seamless thing. So there are administrative fixes that could be undertaken to help streamline that process, because women who get a diagnosis, the first thing they want to do is start on the road to battling the disease and getting to recovery. They don't need delays in that process. You could also improve authorizations, as the providers discussed with us, those that worked within those programs. They were very frustrated by the amount of time that it often took for them to get particularly diagnostic tests approved. Also, currently under the BCCTP program, there is an 18-month care limit on the breast cancer care and a 24-month limit for cervical cancer treatment. We are happy to learn that Senator Tony Atkins here in California has filed Senate Bill 945, which is going to, in effect, remove those limits and make it more of a, this is what the doctor says the course of treatment is going to be, and so the coverage will extend. Some women can absolutely get their full treatment in 18 months, but for those who need more than 18 months, they shouldn't be told, you're done, you're out the door. And finally, continuity of care. And again, this is one of those prime issues where state laws currently say that if you, during open enrollment, your employer changes your healthcare offerings and you have to pick a new insurer and your doctor is not on your new insurance company, you're protected and you should be able to continue with that doctor. But that is not happening in practice. We heard time and again about women showing up to doctors' offices to be told, sorry, we're not on your insurance anymore. Or that the medication we had prescribed you, your insurer doesn't cover that anymore, and so we're going to have to start over again with a new medication for you. So some of the fixes to this could be that you strengthen the mandates. Obviously, some providers aren't living up to their end of the obligation, but there also needs to be an increase in patient education. And again, this is another function tied back to that a navigator can help with, because a navigator would be aware of these things and other patient rights that when you're fighting breast cancer, you may just not think about, such as the Family and Medical Leave Act. We heard a lot of stakeholders talk about women not being fully aware of their rights under that act to be able to take the time off from work to care for other people. And so there's maybe some patient education that could happen here, and some opportunities to improve that very easily, it would seem, since the law is already on the books. So those are the main areas that we are focusing on. Dr. Ponce and I already did some meetings up in Sacramento with some state agencies and some state lawmakers and got a very good response to a lot of these issues. Again, surprised about some of the things that were already state law and shouldn't be happening in the field. And so I'm very proud of this work that we did, and that this study is illuminating that what women are facing in the doctor's offices, in their homes, in their places of work, as they are dealing with this disease. And there are obviously some easy opportunities to help address these barriers and improve care for them. Thank you.
Okay.
Thanks, AJ. So I would actually like to call Beth Glenn up here, and AJ come stay for some of this discussion. And I'd say that, the center works with advocates and policymakers and research organizations to, come closer, you're out of camera Zoom. And Riti and Michelle are not here, and neither are Sarah but three out of them.
We have a quorum.
We have a quorum. That I think what I like about this project, and because it showcases the Center for Health Policy Research that we're prepared to answer questions with big and small data. with real and past data, with data that forecasts. And again, to emphasize that the lit review was important, but at the time that we were trying to get insights post ACA, a lot of the findings were prior to the rollout of the ACA. So that's why it was very important to get the current to get current insights.
All right. Hi, everyone. So the way we do this is we take a question from the room and a question from online and so on and so forth, just to be fair to both of our audiences. So I'm going to start and see if there's a question in the room. Subadi.
Thank you. This is some very interesting data and findings. I was curious about your recommendations related to the continuity of care barrier because, well, I think patient education could certainly help in a situation like the one you were describing. It seems like there might also need to be some provider education because if as a patient you go in and you know your provider is supposed to allow you to continue to go there, but you try and tell your provider that and your provider says, well, you're not covered, sorry. What is your next step then? Just knowing that they're supposed to let you continue, I think, doesn't really help you.
So there's two challenges to that, because the thing that you do is you report them to the state agency, and there is a mechanism for doing that. However, that further delays your care because you showed up expecting an appointment, a test, a treatment, whatever, and now that that's not going to happen, most women, aren't going to wait for the state to then rule and come back to the provider and say, no, that you must do this. And so, unfortunately, you're right. Provider education is very much a component of this, but the current process that is available to women to try to mediate that situation is not necessarily in her best interest, given the time that it would take to go through that process.
So I think it's related to one of our other themes, which is patient navigators or community health workers, or that could be promotoras. So it's as AJ said, it's a complex disease. Probably not, maybe there might be some other diseases that are complex because you go in and out different. The radiation oncologist, the surgeon, the oncologist, your primary care. If you have a comorbidity, then you may have to go to another specialist, and then you have to make these tough decisions about whether you're going to have chemo or not. If you're early stage, and then you have to make some decisions about perhaps, if you wanted a prosthetics delay because of your deductible or a copay, and then all the outside the clinical care, which is the WIGs, the child care. So I think patient navigators could also help with rights with continuity of care, because I didn't know, it happened to me where I changed insurance plans and my provider said, we're no longer one of your providers. And the lawyers at DMHC said you had the right to complain because they had a list, and there's a law that if the provider list is the most current, they need to see you. But you had how many days? About 100. There was a set amount of days where I had to complain, but that takes a lot of health literacy and patient engagement and know-it-all. And so I think it could be handled from the patient advocacy education, perhaps through a patient provider that can help navigate, not just through going from one appointment to another, but navigating this continuity of care. It could also be re-examination of a mandate. Re-examination.
So from online, we have two somewhat related questions. One is, what laws currently exist to protect women from these barriers, but maybe are not being implemented as well as they should? And also, people would just like more information on the legislation, the proposed legislation to extend BCCTP coverage.
Well, I can speak of the interpreter, the right to interpreter laws. That's been on the books. You know, your child should not be interpreting for you, and that's against the law. And California, I recall, again with partnership with California Pan-Ethnic Health Network and using data from the California Health Interview Survey, helped CPAN then help you know, suggest a bill that mandated language assistance services. It was a Language Assistance Act, you know, for health plans. And so health plans had to provide language bridging services if they met threshold languages. But we're still hearing that there are, you know, that interpreters aren't available and that there's language barriers. So I believe it might even be Senator Atkins again that introduced a refresh. I'm trying to examine whether there's compliance with this law. So that's one particular one, a language access, that is being revisited because we're hearing from this study, we're also seeing it in population-based data on CHIS that there's folks that are not getting the right to the interpreter. So that's one particular law. And then the example I gave, Gwen, and to our audience member who asked this question, on the rights for continuity of care. There are mandates that in our other capacity at looking at through the California Health Benefits Review Program, there are protections and mandates on cost sharing for expensive outpatient chemotherapy drugs, for example. So there's one law that's about to sunset and a new bill that's looking into trying to continue with a cost-sharing cap on outpatient chemotherapy. So there are also some laws that try to get at affordability.
Oh, excuse me, before we go on, can we just talk about the proposed legislation that they mentioned? Do we have more details on that?
Yes. So the proposed legislation removes the month limit, and it bases it on a woman's treatment. So that if a woman takes 20 months to get fully through all of her treatments and then through reconstructive surgery, for example, that's still termed under her course of treatment, and that would be covered rather than them cutting her off at 18 months. So it makes it more of a determination on an individual basis, that when a doctor and a patient say this is going to be your course of treatment, and they get to the point where they say, okay, you know, your treatment is done now, and now you're entering a monitoring phase, that is what would be covered rather than just, again, the seemingly arbitrary 18-month limit.
Yeah, as a health economist, of course, there's going to be concerns about if you don't put a threshold, and there could be waste or moral hazard in the system. But I do note that the BCCTP is a federal state program. In the federal program,
question in the room?
There are no time limits.
I have a question because I'm a reporter with a Chinese newspaper company, so we're very focused on the Chinese community. So I have a question about, you just mentioned about the cultural issues in this field. I wonder if or not, is there any kinds of organizations or some kinds of groups just focus on the immigrants of females' health, especially in this field. Because according to some studies, there's maybe the opportunity of get the breast cancer maybe enhanced because of the immigrants' experience of some Asia female. So I don't think, I'm curious about if or not there maybe have a chance to get some kind of organizations to, like you say, just get the navigators and get the chance of education to hear about this message you want to present to us.
Say there's an organization that's in the San Gabriel Valley, the Herald Cancer Center. I can't remember the exact name of it, but I don't know if you're familiar with that organization, but they're an organization that specifically serves the Asian population for screening, for breast cancer screening, but also to help women and men access cancer services. So I know there are organizations in Los Angeles that are working in this issue. And I also know that there are people doing research also to look at differences in the increased risk for breast cancer that they have seen among Asian women with increasing length of stay in the US. So a lot of that work is being done through the California Cancer Registry data, some of it being done by the Los Angeles Cancer Surveillance Program, which is actually based at USC. But they're doing that work to look and see what are the risks. And then I know there's groups in the community that are working to try to actually improve access among Asian women.
And if the woman is low income, there's been a longstanding tradition of cultural and linguistic access to services that's embraced by community health centers, particularly those that serve predominantly Asian and Native Hawaiian and Pacific Islander populations. I think one of the surprising findings, I don't know if it's surprising, but counterintuitive findings was that navigation, the women who had commercial insurance actually were the ones where it was uneven in terms of navigation services. Some of it had it, some of it did not. But for women in safety net programs, county hospitals, community health centers, they were more likely to have navigation.
Okay, from online and related in a way, what are the researchers' thoughts on special circumstances and barriers faced by undocumented patients?
So I think that the Every Woman Counts screening program and the breast and cervical cancer treatment program has provisions to provide treatment regardless of documentation status, but those women who are undocumented, I believe, would get partial scope Medi-Cal. Those that are eligible because of immigration status and income, then would go to full scope Medi-Cal. So that would be an option for women. And then there, of course, are county programs on healthcare, like My Health LA, Healthy San Francisco, that would be another potential source of care that provides care regardless of documentation status.
Any other questions while we wait?
Thank you for this great presentation. I'm wondering if you could say a little bit more about what you learned about the patient navigator programs in terms of their mix of prevention focus, treatment focus. I know that your study is focused on treatment, but I'm curious if you learned anything about how much continuity is in that navigator models, in those navigator models that you heard about.
Very little is the short answer to that, because we heard from one woman who not only was a patient educator but was herself a survivor, and her experience was that she had private insurance and had a navigator that was provided by her insurance company, and then she switched jobs, switched insurance companies, and the second company didn't provide a navigator. We also heard about women getting diagnosed here in Southern California through the Every Woman Counts program and being deliberately sent to certain hospital facilities if it wasn't too far out of their range because the public program there provided a navigation service. And so a lot of times the educators could try to help direct women toward a path that would get them connected with another navigator. But the women who weren't able to do that, we heard a lot about patients who would come back to them, even though they were maybe with the Every Woman Counts program, and they were on the outreach side. Patients would come back to them later, particularly if I heard this a lot from the women we talked to who were Spanish speakers, because the Spanish speaking women would come back and feel more comfortable talking to them and ask about services and ask for help with certain connections and how do I do this and that kind of thing, because of just a comfort level with people. And so again, there's people who might be considered navigators today, whether it's an official title because they work within the health system and they've been given that title, or they just happen to wear that hat because it's convenient. One of the providers we spoke to essentially said it was his receptionist because she interacted with everybody, and so she was just the one who ended up doing that. So it is so not, there's no concrete avenue toward getting a navigator and getting help through those services. It's really the luck of where you are, who you go to the first time, and whether or not that service is available where you go.
And I think, Catherine, your question relates to one of our recommendations of standardizing, patient navigation, and specifically standardizing patient navigation for oncology care. Beth knows the literature more, but I'd suspect that patient navigation is more in the screening, in the referral, and not as much in the treatment.
Yeah, I was going to say, I think there's just this disconnect, which we see also just in the safety net system, that we have only certain services that need to be done in the hospital or with certain specialist providers, and then a lot of our services can be done in primary care or through special screening services. And so that link between the generalist or the person that does the screening and the specialist is a difficulty here, as it is in many of these other areas. And so I think that there aren't a lot of programs, but if there are, they're the better programs that really span from like initially reaching out to the woman and saying you need to get a mammogram, all the way through to let's make sure your treatment gets finished. And I think that's kind of rare, because unfortunately there's a lot of handoffs that do or don't happen that make it really challenging.
Can you comment on the state treatment authorization request program navigator process? Our experience for cancer TARs is potentially a 45 to 60 day approval process.
Can you comment? We can't at the moment, but
okay, Bradley, write us about that.
We'd like to hear more. Okay, Bradley.
Yeah. Okay, any other questions in the room?
Thank you for the very interesting presentation. My question is, how did you choose the key formats for the interview? And another question is, do you have some data to show the effects of patient navigation on outcomes?
So the selection was done by trying to identify women who, or not women, people who served in a capacity such that they interacted with a lot of breast cancer patients.
Across different health insurance
right. Interviewing patients would have been isolated, right? We would have gotten one patient story at a time, where when we talk to educators and advocates and navigators and social workers and providers who saw multiple patients, they got a bigger picture and they got a bigger understanding of what their patients would come in and tell them and what feedback they would get. And so in some cases, some women had built up relationships with these people, and so they could speak to not just one single patient's experience, but look broadly across, speak for a lot of women and understand a lot of experiences. Also, they were able to identify the actual gaps. One of the patient educators we talked to had this patient come back to them, and she was an African-American woman, and she was lamenting the fact that there were plenty of organizations that if you were Caucasian, you could go get a wig from, but there weren't really many that were appropriate for her. And so from her perspective as a patient, the barrier was, this doesn't exist. And the patient educator had the bigger knowledge and understanding to say, oh no, that does exist. That service does exist. So the barrier isn't that service doesn't exist. The barrier is that the service and the patient who need them aren't connecting. There's a gap there. And so we wanted people who could identify those stories. And so we put out a call through different advocacy networks and patient educator networks that are identifiable, and said, would any of your people be able to speak to us about the patient experience? And then similarly with providers. We were a little more specific with providers in that we wanted to get primary care providers, we wanted to get oncologists, we wanted surgeons. Yeah. We also wanted other people, right, like social workers and navigators who worked within the provider site, as opposed to the women who were more community focused. And so I feel like we both got diversity in the conversation, but after we did phase 1 and then we launched phase 2 really reinforced what we heard in phase 1 and added on to it, which made us feel much more comfortable in the results that we put forward, that there's no misperceptions that something bad is happening that isn't happening. Everybody sees it, and it's a gap that needs to be addressed.
And AJ, can you speak about the geographic diversity? And I'm going to tee it up for Beth to talk about the patient navigation literature.
Yes. we also, obviously, California has some very diverse geography to it. Both there is big population centers in the south in Los Angeles and San Diego, and then up in the north with Fresno in the middle of the state, and then up in the Bay Area. And then there's a lot of very rural areas that have a very different perspective. And so we definitely tried to diversify and make sure that we were hitting all of those spots, and also getting people who worked, as she mentioned, with healthcare clinics or with a private setting such as UCLA, because those two provider settings are going to see potentially very different populations of patients and have very different experiences to share. And so we tried to stratify that as well.
I was going to mention that there is a growing body of literature to support the effectiveness of patient navigation on some outcomes. So there's more actually on the screening side, and also on the, like if you have an abnormal screening test, you need to get into treatment, but there's actually less data and less of an answer about effectiveness for treatment completion, but there is some literature to suggest that it's improving. So, and there's a lot of interest, and there's a number of studies that are still in the field to look at treatment completion as the outcome.
And we do note some of those in our report. So if you want to follow up.
We have about 1.5 minutes. Can I squeeze in one last question? Because it's germane to what you guys are talking about. Where'd it go? Have you found that the navigators have to use a different process for patients with Medi-Cal versus Covered California versus private exchange or employer-based insurance? Wondering if, in the end, these patients are able to access all of the same services, or if low-income patients are actually can't access the same services.
So it's not just services, as a matter of fact. Depending on which insurance company you have, and perhaps what type of insurance you have from that insurance company, might change what tests you get covered. And so, unfortunately, it's not as simple as saying, well, if you're in this bucket, if you're on Medi-Cal, or if you have private insurance, that this is your experience. It varies dramatically under, as Ninez was talking about earlier, are you on partial scope Medi-Cal or are you on full scope Medi-Cal? And so there's a lot of diversity, unfortunately, to what you get. And in terms of the navigation services, two people that both, for example, and I'm totally making this up, have Anthem Healthcare, but one lives in a place where they can go to a comprehensive breast cancer center, and one lives in a place where that's not available. They're going to have two very different experiences despite having the same insurance. And so there is no one straight answer to that, unfortunately.
However, we do cite a study from UC Davis, that a large empirical work that shows that there lowers 5-year survival rates by insurance status for women who are on public
All right,
insurance.
on that depressing note, we have to end because we have to stay on time, but I want to thank the speakers and all our participants, and hopefully good will come out of this.